Please don't mind, I have a very bad medial ligament tear, so I was actually trying to recuperate myself. Sorry for the delay, sir. Respected the audience and the learned doctors sitting on the dais, Dr. J.C. Mohan sir, Dr. Shamitra Kumar sir, and everybody who is over here this morning, Sunday morning, I welcome you all. The first talk was amazing. It was full of data and full of information. A lot of things I probably won't do in my setup. I work in a very small place in Bhagalpur, Bihar, where all those bubble studies, even though I've been doing it long time back in Alabama, I can't do it in Bhagalpur. The point is, my case is very, very, very practical, because once you do an echocardiography, because we are not only an echocardiographer, we are also a clinician. So once we have an echo, what actually the advice we have to give to the patient. That is one thing which I really have to think, and I need to talk to my colleagues and seniors. See, I saw this on my patient. Now what? When should you follow? What advice has to be given, or is there any documentary evidence, scientific data to go on? So actually, the finding and the advice to the patient is very important. As a clinician, that is what my case is. It is very simple. You probably will gonna say, oh, this is very, very, very simple, but there will be some take-home messages. So this is a boy who came to me just 4 days back. So please mind, I have done a video by capturing the video on the screen. It is not a real video, but I'm so sorry. This is a 26-year-old boy. Remember the age, 26, young guy, who actually went to gym. And he did a lot of exercise, as everybody does, and he got breathless. For the first time in his life, he got breathless, and he had some pain, abdomen, some tiredness, some vague symptoms. But he had no chest pain. It's a very important point. He had no chest pain and no prior breathing difficulty. It was only that he cannot take deep breath and some difficulty in breathing only on the time when he was doing the exercise. So he came to me, and the first thing was that I took an ECG definitely, and then did an echo, and of course the blood test. I'll give you the picture of the blood test. This was done just a few days back on 15 July itself. He had little bit of borderline raised serum bilirubin 1.26, which after 3-4 days became normal. I don't have the value here. And overall, everything is fine. The blood pressure is okay. It's not he's not hypertensive. He's not overweight. His pulse is less than 60. It is 54, again to be noted. So this is SGPT, SGOT is little on the high normal side. It's not nothing abnormal. He had no history of alcohol or any kind of addiction at all. Everything was fine. He came with his parents, actually, his very concerned parents, very much. They had 100 questions to ask, actually. Now, when I did an ECG and echo, I'll show you the picture of ECG first, and look at the ECG. I think if I can do the interaction right now, you will have a differential diagnosis right there, then and there. You can see we have been talking about this yesterday whole day, and I think we are all armed to the teeth about what this ECG is. You can see all those T wave changes, deep inverted T wave changes, lead 1, 2, 3, all those things. It's all very obvious, right? I think you know what it is. Answer is obvious, right? So it's very obvious. So what I'll do is I did an echo. I'm just going back to the slide, and what I found was, you will tell me. I want you to concentrate not only on the LV, but on the aortic valve, mitral valve, LA size, IVS, RV, everything, not just what is actually obvious. Pulmonary valve. See, I've taken the picture from the screen, so please don't mind, the quality is not that good. Flow. LV apex, apical area, typical spade. Now if we go to the another one, now this is very obvious, the first picture. Everybody knows this, right? Is there anything wrong with the aortic valve? If I can ask maybe later on. Is there anything with the LV apex? Which is very obvious, of course. This is something I have brought because even I am confused as to, am I dealing with the pure form of what you all are thinking, or is it something else? Now, if the color flow is okay, a little bit of LA enlargement, I think it is very obvious. IVS is definitely thicker, posterior wall is thicker. Your aortic valve was a little bit thicker. Then you have a LV apical, there was something there, spade-like appearance. So I think it is obvious, I believe it is what? Cardiomyopathy, apical, correct? I believe, yes. Do I see, I hear yes, yeah. This is apical cardiomyopathy. Now this is in 26-year-old boy. Now imagine, as I told you, the parents are they are actually lawyer. One of them is lawyer, another one is somewhere related to police. So this is a very weird combination, police, lawyer, and they have come to me for a final answer. Now this is kind of patient which is probably going to go for litigation, and I have come here today only for this reason. See, we talk a lot about this apical cardiomyopathy, but what is the take-home message we have to give to a patient who is 26-year-old? How we have to follow the patient? Academics definitely is very good, but how we have to follow the patient, when we have to call for the patient for echocardiography, what all other tests we have to do to rule out any other pathology which is expected in apical cardiomyopathy. So if I go further, do I have a unanimous decision that this is an apical cardiomyopathy, sir? Is it an apical cardiomyopathy?
There is no doubt that this is classic apical hypertrophic cardiomyopathy. We haven't seen the aortic valve that well, but I do believe the aortic valve probably is all right. In a 26-year boy, apical hypertrophic cardiomyopathy, what are we trying to look at? We probably would need a family history and maybe screen the family members. That is the first thing. If, of course, facility exists, and I don't know, and you rightly said that in a small center facility may not be available. The two more things which we need to do is a cardiac MRI, more so to focusing on the late gadolinium enhancement. That will also show whether this apical hypertrophic cardiomyopathy is associated with any apical aneurysm and the other high-risk features, plus, of course, genetic studies. Having said that, most patients with apical hypertrophy have a relatively benign prognosis. They continue to do, barring actually competitive sports, everything else is all right. They have a relatively benign. I have a good number of people, we have followed them for 20, 30, 40 years. Nothing happens to them. Unlike, of course, the mid-cavity obstruction and LV outflow tract obstruction.
Yes, sir. This is really informative. Yeah, Dr. Mishra, Dr. Samir Srivastava.
Just go back to the ECG, please.
Yes.
I thought there was a delta in the PR.
Right.
That
Oh,
is
yes.
the thing.
You have been catching that short PR interval yesterday also.
PR,
Yes.
How much is the PR?
It's around 0.11.
And initial slurring is also there.
Yes. That is what was very catchy. Thank you. I mean, great.
So, is there any history of arrhythmia?
No, that is the point. He had no history of atrial fibrillation, arrhythmia, no family
So,
history.
what was the presentation?
As I said, just when he went to the gym, he had some difficulty in deep breathing.
Difficulty while exertion, okay.
Exertion. So this is, you got it very right. There is something to do. There is something going on. Short PR, delta wave is, yes, very nicely correct. Thank you. But then this is the patient, as I said, it is a high-risk patient going for litigation very soon. Young patient, 26-year-old, what advice you have to follow and give, because this is going to be documented, and I believe everybody, all of us who are here in Bhagalpur, Calcutta, Delhi, Bombay, Nasik, they should all give one advice. So this is the platform which I really want to know. How are we all going to present and write advice to follow up to be done, so that when I write 6 months, come after 6 months to do an echo, come after 1 year, maybe you will write no, come after 2 years, because we don't see a lot of death, is only maximum few people have died. So this is the suggestion which I wanted from the audience. If we have some unanimous plan about how to follow this patient, it will be very helpful for me. And of course, LV aneurysm is what the sir said. Definitely, I was looking for LV aneurysm, even though I didn't have a bubble study, but I tried, as Dr. Allegation was doing yesterday, tried to go open the LV apex through all those, views, and I did not find any aneurysm, definitely. So, as I said, we know about hypertrophic cardiomyopathy, a lot about it. It's very obvious you have obstruction, SAM, and mid-cavity obstruction. But this patient had nothing to do with that. Now, if this is the patient when he comes to you, this is something theoretical. We don't have to go through that when it was reported. I'm just skipping it. The point is that we have to look for and follow for the arrhythmia, as very smartly was picked up that maybe this patient will go for arrhythmia. So how should we warn the patient about all those possibilities of arrhythmia, like atrial fibrillation you can have. So that is very, very common cause of palpitation when the patient can come. So as we said, as Dr. Mohan sir has said, that chances of mortality is quite low. Definitely, it is very, very low. But the advice and the follow has to be copy and paste among all of us who are actually doing this clinical practice. So my main mission of presenting this case, this simple case, was that we should not fall in a situation where we get litigation as to you didn't do the follow-up correctly. So as we said, again, there is theoretical aspect about apical cardiomyopathy. I think this is more of a theoretical thing, like you have a relative cardiomyopathy, mixed cardiomyopathy, apical I'm talking about, and the pure form. So let's not go. This is more of academic, and I'll skip to it. As I said, it is very common in men who are older than 40. But this is a boy who came in 26. So average. This is the data, which is actually not very clear about the data. But then, as I said, the T wave which you saw, the inverted T wave, probably might be missed. It might not be there in apical cardiomyopathy. Again, it is nothing like 100% confirmatory. So everything has to be included, even the genetic study, which is not possible in small centers, but then it is all going to help. But my presentation reason was to make sure that we have a take-home message on our advice, and we have to rule out other things like Fabry disease also in athletes, as we have talked about it yesterday a lot about it. Let's not talk on it. So I think I'll close down this, and this is how I want to end. And I am really looking forward from the inputs from everybody as to what should be the documented take-home messages for this patient. Thank you.
You need to give some occupational advice also.
Yes, I told him that he cannot do any kind of gym kind of the heavy weight lifting. He can do a little bit of aerobics as normally everyone does. He cannot be a marathon runner. He cannot be an athlete, all those kind of things.
About isometric exercise.
Yeah, the weight lifting and those things.
In the apex, if you interrogate, at times there is some flow crunch. If you track the color flow
Correct.
into the apex and see the enlarged view, you may find some crunching there in the apex.
Any final comments or questions from the floor? Otherwise, we'll call upon the next speaker.
Ashish, did you attempt to take gradients across the apex?
Yes. Hold on. Maybe if I have the recording here. Yes, the first one, the left side. This one. That's look at the cursor is little on the apex. This is the cursor here. And another one again, it is on the apex. The cursor, look at the cursor here. Apex, I have taken. This is it. There is no gradient. Nothing.
I just wanted to give a input. Is that yesterday one paper came in International Journal of Cardiovascular Ultrasound. They have said that patients who are in cardiomyopathy, if they are trained, this is a retrospective data of around 14,000 people. If they go for a regular good exercise training module from an adolescent age group, then their chances of having sudden cardiac death is lesser as compared to people who are not trained. So I think this is a very important point, because you're telling that this is a younger person. So I think the future will be a good exercise training platform if we have an exercise modulation, can have some outcome thoughts. Dr. Mohan, what do you think? I can share with the paper. This is yesterday's paper.
To be honest, we keep seeing a lot of apical hypertrophic cardiomyopathy. I haven't applied my mind. I do understand there is some pre-excitation. We didn't really talk. Pre-excitation is actually known to occur in some heart disease. Hypertrophic cardiomyopathy, one of them, Epstein, another, pulmonary stenosis, the third one. These are the three usual structure heart disease where you see pre-excitation syndrome. Does the pre-excitation syndrome have different prognostic connotation in this patient? I'm not aware of. At least I haven't read anything. But of course, you might say that let us go to extreme, do Holter, repetitive, do an ELR, maybe even do a electrophysiology. I think that is, no such a recommendation exists. As you rightly said, there is a big gap with regard to our knowledge. But apical hypertrophic cardiomyopathy, of all the hypertrophic cardiomyopathy, continues to be relatively benign. And my suggestion is, barring competitive sports, everything else is okay. Should they be doing this thing? I still would not suggest, but I do want to find out the markers of high risk of sudden cardiac death. Late gadolinium enhancement, definitely. The apical aneurysm, I definitely want to see. And also, overall, I would like to see the ECV also. If even in non-thickened portions, the extracellular volume is increased, I would, I would be a little more careful about these patients. Still, drug treatment probably may not vary. I may still give some beta blocker, but this guy has sinus bradycardia.
46.
Even that is not a very, very great advice with regard to that, or for that matter, any of the calcium channel blockers. So we probably, maybe he's well trained, and that is why he has this bradycardia heart rate 56. Maybe he doesn't have it. A Holter may be desired actually.
The question is still unanswered, like when should I call this patient for echocardiography?
So the appropriateness criteria say that you should actually be doing echo once in 5 years.
Once in 5 years?
Yes,
Okay.
2019 appropriateness criteria say, unless a situation changes, in apical hypertrophy situation not going to change. So they say, if patient develops new symptoms or every 5 years.
Okay, thank you, Dr. Sinha. Oh, question?
There is some data also, those patients who are symptomatic, in spite of having apical cardiomyopathy, those usually have sarcomeric mutations. So in young patients with 26 years, I would like to go for the entire prognostication first and then follow up for 5 years, because early death has been found initially, it was found to be benign, very apical cardiomyopathy. But in females, young, and European, along with the LG more than 15%, along with the sarcomeric mutations, it is, and with a family background, these are very high risk. So prognosticate and then follow up with a benign course will be better.
So do we all agree with 5 years, or I told him to come every 2 years? I really don't know, because I was a little skeptical.
Do it, but the things are not going to change.
Okay.
I think you first decide the risk of the individual by other tests.
Okay, fine.
The sarcomeric mutation is also a good idea to find out. The CMR is a good idea. Maybe a Holter is a good idea. But family history is a good idea. Family of sudden death actually in family is an important issue. And then we can decide what to do. But there is a lot of gray area actually in apical hypertrophic
Yes, so
cardiomyopathy.
It
that
has
is-
to be
that is-
individualized.
You- we-
So
we-
that I think is the take-home message.
And I can also tell you, some person in this individual might suggest, okay, you have little LG positivity, I'll give you an ICD. It's also possible.
Yeah.
But
Yeah, that is one question. ICD should be given, because you saw that short PR interval, he will go for fibrillation, something will happen. So do we preventively do some ICD? Somebody is going to suggest.
I don't think
No,
that's...
so we don't do it.
Okay, we'll take it up for further discussion during our luncheon session. Professor Dalgishas, please call the first.
I think it is Ishita. Ishita, are you ready?
EP study. EP
EP?
study.
No, usually not required until unless the,
There was a short PR, so should we do EP study? Yeah, you rightly asked.
even then, if there is no history of arrhythmia,
Yes, he had one episode of palpitation during exercise,
but
not
palpitation
later.
is a
after
very
that.
non-specific thing. Palpitation, you have to elicit whether it is a rapid type, whether it is slow type, irregular type, regular type, until I take a detailed history about the palpitation.
But I'm a little concerned about his non-alcoholic fatty liver also.
Yes.
His enzymes are raised.
Yes.
I would probably look at that also.
Yeah, that was confusing. That is why I brought it here. Thank you, sir.
Dr. Majumdar, please.